Hello, my name is William Porter McRoberts, MD. I am an interventional spine doc and interventional physiatrist who lives in Fort Lauderdale, Florida, practices here. Today I'm going to talk to you about sacroiliac joint dysfunction, treatment, physical therapy, injections, ablation, surgeries, fusion, and all the different options that exist for this joint. It's a very, very interesting joint, all of the way to the upper body weights on this joint. And so it is an incredible mimicker of other problems such as disc herniations and sciatica. I want to talk to you about it because I think there are very few people who can connect the entire spectrum of treatment for the joint like I can. I do it all. I also live with a problem myself, and so I've been dealing with this sacroiliac joint dysfunction for about 20 years. And so my understanding of how it works and how it affects people day to day is probably very different than most physicians. I'm a real student of the joint. I have taken great care in learning about how it works and how it doesn't work. And so today I'm going to explain everything there is to know in segments. Some may want to just see the first part. Some may want to understand what a fusion is. Some may not be getting relief with injections. I'm going to cover everything there is to know, and hopefully in so doing, give you the tools to treat this yourself, make educated decisions yourself, decide the next steps for yourself, develop a good idea of what you need to ask your physician, what the risks and benefits of everything are, and essentially why this joint seems to be an Achilles heel in the human animal, and what we can do to make life with this joint easier and better. I hope you enjoy this. I hope it helps you. So this is it. This is the sacroiliac joint. It exists between the sacrum and the ilium, hence the SI joint nomenclature. It is the entire weight of the spine resting on the sacrum, which then translates to the ilium, which is the pelvis. This ilium is where the babies come out, right at the base here. This is the pelvic outlet. This is your coccyx. And this is the actual joint itself. I don't know if you can see that, but it's not a massive joint. It's on either side there. It's about half the width of your palm in reality. And it sits right in here. And what you can't see on this is the incredible work of the ligaments and fascia and muscles which secure this joint and the ilium to the sacrum. Of course, there's nothing holding it together except for ligaments and muscles. And that's an incredibly important thing to understand, because those are the only two friends you have in securing this joint until you get to metal, which is what we hope to avoid. But the issue is that this joint moves very little naturally, only about 1.5 to 2 degrees in the normal Gait cycle. That is somewhat important, but what is most important is that this joint is stable. Essentially, every problem that arises from sacroiliac joint dysfunction comes from instability. That instability arises from weakness in or laxity of the ligaments and muscles which cinch it together. It's kind of like having a shoe designed for laces, and if the laces get weak or sloppy or removed, the shoe wears out much more rapidly. And that happens after a sprain of the joint or a lengthening of those fibers that secure the joint, that the joint then becomes unstable. And in its instability, it starts to move. And in its movement, it ultimately starts to form arthritis because it moves outside the normal range of its physiologic movement. And you develop arthritis within the joint, and then pain and all the things that we do to try and make you feel better. There are some things that happen along the way that can open your eyes to the joint. Not frank arthritis, and we'll get into that next. So we have the joint here, and a lot of people ask, well, why do you even have it? If it only moves about a few millimeters at most, or a degree to a degree and a half, why even have it? Why just not have the sacrum fused to the pelvis? Well, as you know, fitting a baby's head through this opening is somewhat challenging to a lot of people. And this joint, the relaxation of this joint, during the terminal time of pregnancy and childbirth actually allows the pelvis to open and permit the passage of the cranium through the pelvic outlet. And so this joint allows that to happen. Without it, our brains would be much smaller, heads would be much smaller, and maybe evolution itself would have never occurred. But nevertheless, this joint does relax and move, and it is important in that. What it also does is it changes the way in which we walk. As the pelvis moves and twists, as you go through your individual gait cycle, bringing the femur out before the heel strike, you actually reach out and the pelvis twists, and in its twisting, it softens the blow of the landing of the calcaneus, of the heel on the ground. And in so doing, it's one of what we call the determinants of gait. There are actually 6 determinants of gait that make the function of walking not just more efficient, but also less traumatizing on the skeleton. All of those things serve to essentially reduce the motion of the sacrum to about 1.5 to 2 inches as we walk. If you were to place a marker right on the sacrum and x-ray a patient or a person as they walked, you'd see the elevation, the rise and decrement of the sacrum to be about 1.5 to 2 inches. The fact that we're only raising and lowering our bodies so little makes us efficient as we walk over great distances. And it's because of that that we're so efficient in our walking and our stride. The problems arise when this SI joint becomes hypermobile, and there are a lot of reasons that that can happen. So the 4 reasons that the SI joint can hurt are essentially this. Number 1, it starts with straining the ligaments. This is a minor issue. It's not a sprain. A sprain is actual tearing of the ligaments. But a strain is when one stays in one position too long and the ligaments elongate or stretch, thus allowing a greater degree of movement or freedom of the joint over time. A lot of people are side liers in bed, for example. They lie on the side, they hike one side of the hip up, and they throw a leg to stabilize them so they don't fall over on their side. That, over the hours of the night, that pelvic asymmetry and the motion of pulling that femur up and then nutating or moving the ilium posteriorly will, over time, over the hours that you sleep, night over night, week over week, year after year, will gradually lengthen those ligaments, and it will, in time, make the joint more mobile. That is a way to lengthen or elongate those posterior fixing ligaments, we'll call them that, we'll get into it later, very easily without you really even knowing you've done anything wrong. A lot of people lie on their side. What are some other things? There's certain activities we do, big squats or anything that requires pelvic asymmetry. Quite honestly, sacroiliac occurs more commonly in ladies. Why? Because of childbirth and relaxin and other types of peptides that actually cause relaxation of the joint capsule and of the ligaments that surround the joint. But as the joint becomes hypermobile, it starts to move. And when it starts to move beyond that physiologic range, you can have essentially locking in either nutation or counter nutation. I'll tell you exactly what that is. A lot of people will experience it because they will say, my back, quote, went out and I was doing nothing. I was picking up a sock or turning on the gas on the grill. For me, it was I was bending over in surgery and leaning over a patient. It was about a long 4-hour surgery, and I stood up and all of a sudden there was something wrong. I'd never had back pain in my entire life, and I had about a 6 out of 10 pain. It was very significant, unilateral, one side only. And it took me a little while. I was in fellowship up at Emory before I realized I had nutated my sacroiliac joint and it was stuck. It had actually moved and twisted out of the physiologic range, and it had gotten stuck in that position. And I was in extreme pain until a good friend of mine was actually able, who's an osteopathic physician, understood the SI joint better than I did at the time. And he was able to provide a few thrusts and with some body motion and movements and some muscle energy techniques, able to relocate the joint. And I went from a 6 to a 0. And in that holy moment, I became a believer in the SI joint, that it not only is very important, but that it can really hurt, really get your attention, and essentially render you functionless because it's so painful. So in review, The beginning of an SI joint problem is really a problem with hypermobility of the joint that comes from stretching of the capsule and stretching of the ligaments from living in pelvic asymmetry. It could be the way you sit, crossing your legs in a certain way that becomes a habit, sitting on one leg and not the other, for an example, lying on your side. Certain activities will do it. Certain lunges and squats over many, many repetitions will do it. And it will lengthen those ligaments and will increase the dynamic range of the joint to a degree, at which point you can lock the joint. So there are really 4 reasons why it hurts. 1 is a strain of the ligaments. It can hurt a little bit. It's a small amount of pain. You develop an ache in the low back. There's 2, an actual sprain of the ligaments. This occurs from either trauma, or if the joint gets locked outside of its physiologic range for a period of weeks or months, it will gradually tear those ligaments. 3, an actual emergency situation where the joint is nutated beyond its physiologic range. It becomes essentially dislocated and locked in that position. And then ultimately 4, which is where this process has been ongoing over the years, and it has gradually turned into arthritis because the joint has been so abused and the body has now worn out the cartilage within the joint, and it becomes painful essentially all the time. Those are the only 4 reasons it hurts, except for trauma, bullets, cancer, which is very rare, but pretty much everything can be dialed right back to that physiologic range of motion. There's probably going to be 2 types of people looking at this video. Ones who have experienced either again or for the first time this episodic dislocation of the joint, and number 2, people who simply have had this ongoing issue over the years, and now they're seeing interventional pain docs, physiatrists, anesthesiologists, and ultimately surgeons for treatment of the problem. And so those are the 2 main reasons people are probably watching this. But it starts early. And if you understand, after say a session of dislocation, you're able to get it back in place, what you're up against. And so this next segment will talk about precisely what you can do to stabilize the sacroiliac joint. Let me just show it to you really quick. I've got a CT scan pulled up. I'm just going to show it to you what this joint looks like on x-ray. So CT really is a group of 3-dimensional x-rays. I have a patient of mine who saw her for the first time just earlier in the week. Super nice lady. She's a lady who actually has a multi-level lumbar fusion from L2 to 3, 3 to 4, 4 to 5. She has significant degenerative disease at 5'1", but also, and interestingly, she has developed arthritis in her sacroiliac joint. One of the troublesome things about SI joint pathology is it rarely is seen on imaging. But we caught one in the act, actually on both sides. You can see it here. Here's the back access of the joint. This is a patient whose head is facing this way, feet are this way, a slice right through the middle like a samurai sword. This is the base of their sacrum. These are the iliac wings here. This is the lateral portion of the sacrum, and this is the sacroiliac joint on both sides. So the joint is pretty big. Really, the actual joint is just this anterior portion of the 2 bones. Those are the ones that have the articular surface where you have cartilage on either side. The rest is essentially it's an area, but it's not a joint. It's sewn together with very strong fibers in this back portion of the joint. This is the only articular portion. But you can see something of interest right here. This is a vacuum phenomena seen not uncommonly. It's actually a bit of air within the joint. And you can see the lipping of the joint, the little spurs that have been formed by the body trying to deposit calcium to shore up the joint so there's a minimum of movement. That's essentially what spurring in arthritis is the body's essentially depositing calcium and making bone to try and actually bridge and connect these 2 pieces of bone to fuse the joint. Ultimately, if we were to send this patient to space for 2 to 3 months, that fusion would occur on its own, and she'd actually probably be pain-free. Her pain is in this location on the back, and so when she came in to see me, that's where she said her pain was. Where is that spot? We call it the Fortin finger area, after Joe Fortin, the first guy who really diagnosed it. And he said, Fortin finger spot is highly specific and sensitive. And if you look at your back, it's really at the crest of your hips And right at the base, you can feel the crest of your ilium, which is the crest of your pelvis right here. You put your hand on it and you walk it back right to the base of the spine, and your thumb will fit in a little sulcus right there. That is the top of the SI joint, and if you follow it down, it comes right into the meat of the buttock where the piriformis and glomerular muscles are, as well as the gluteus maximus. And so that's the joint. Often that's where the pain is. People who have sacroiliitis, it's usually only on one side. Sometimes it's on both, but the acute issue is usually a one-sided phenomenon, and it's usually because they have a favorite side to sleep on. I noticed that a lot of folks who have this problem have a triad. They usually have a septal deviation in their nostrils. They can't breathe if they only sleep on one side, so they sleep on the other side. Then they develop shoulder issues on the dependent side. Say if it's your right side down, they get some shoulder pain here, and they develop a right-sided sacroiliitis. I call it the McRoberts triad, but nevertheless, never heard it described anywhere else. Those three things happening together. Not uncommon though. I've asked a lot of patients about it. So, how to shore up this joint? Okay, so let's say you've dislocated your joint, and hopefully you found someone who can relocate your joint, either a chiropractor, generally pretty good at this, or a musculoskeletal trained orthopedic a physical therapist who has a PhD and then is manually trained. These are the two folks who are particularly good at it. DOs, doctors of osteopathic medicine, are actually particularly good at it as well. But I'm going to talk about how the problem comes on, because you have to understand what has predisposed you to this situation before you can undo and remove the predisposing factors and shore it up. There's essentially two types of dislocation. The majority are one, probably 75-80%. The majority are the other. The number one cause of this is something called a nutation, N-U-T-A-T-I-O-N. It is where the sacrum, okay, this part, and the ilium have rotated in reference to each other. And the sacrum has actually moved forward where the pelvis, the ilium, has moved backwards. This occurs all the time. It is the most natural and common type of dislocation. And if you think about it, it's where you bring your femur forward, you rotate your pelvis posteriorly, you're still leaning forward in somewhat the fetal position in the bed or lying, and that position will allow the sacrum to rotate forward relative to the sacrum. Let's say this hand is the sacrum, this is the ilium. It rotates forward like this, okay? And that sacrum rotates forward. Same thing happens in a cycling position, for example. You're sitting with your two ischia, which are the sit bones right here, on the seat, and then you're leaning forward, you're rotating the sacrum forward relative to the ilium, you're pushing the ilium back, and so that stretching moment, that is called a posterior movement of the ilium, or a nutation. Okay, so this is nutation. With the relative to the ilium, the sacrum moves forward. That's the vast majority of problems and dislocations occur with that. It's very uncommon to have a counter nutation, okay, or an anterior rotation of the pelvis. That's where the sacrum moves back relative to this. But if you think about it, it's very uncommon because very few people are doing the rising sun position in yoga, for example. It's very uncommon for people to go into extension at the low back and hold that position for a long time, but it can happen. Sometimes people walking on someone's back can do it during some types of Asian massage, etc. But the majority of people are nutated or posteriorly rotated. The ilium is posteriorly rotated. So the first thing is you have to understand what you're doing to make that happen. And cyclists are a particular risk. Runners, because they're doing a lot of rotation, and then side sleepers, of course. People who are doing lots of lunges, which are asymmetric. Again, what's happening? You're coming down with your femur. The femur is flexing up relative to the body and driving the ilium posteriorly. So once you realize which way the ilium has gone, say posteriorly relative to the sacrum, a nutation, the most common, you've got to somehow bring the ilium back, and in so doing, bring the ilium forward, and in so doing, bring the sacrum back. That's the kind of maneuver you need your physical therapist or your chiropractor to be working on. There are a lot of exercises and there are a lot of different maneuvers that can do that, and the web is filled with them. But I'm going to leave it up to you to search for those or get yourself to a PT or a chiropractor. Once you've realized and you've gotten your joint back in place, and it can still be sore for quite a long period of time, it can be weeks before that pain seems to go away. And a lot of people, the back has gone out and then it got better, sometimes on its own, commonly on its own, because very few people know that they're in a dislocated kind of situation. What can you do to prevent it from happening again? And it's very hard to get people patients to understand that they're in a period of a honeymoon period where essentially the joint is in place, but the securing system for the joint is weak and lax. And that is the thing you have to work on. There's really essentially three main muscles that do that. Number one, and these are all muscles that cross the joint. The number one muscle is the gluteus maximus, not the gluteus medius or minimus, but the gluteus maximus, which starts at the lateral portion of the sacrum. It crosses over the crest of the ilium right here, goes all the way over, comes down and attaches to the outside of the femur, the hip bone. That's the number one muscle. Number two muscle, you've probably heard of it by now, is the piriformis. The piriformis attaches to the back part of the femur and crosses through this notch along with the glomerular muscle, we call it the sciatic notch, and attaches to the front or anterior side of the sacrum. This also sandwiches the joint together. So there are a few exercises that can work on strengthening this muscle, and I've noticed a lot of Americans spend a lot of time looking at this muscle. But nevertheless, this muscle, these groups of muscles, if you can get them strong, they will sew together the joint so that there's a minimum of movement, or at least a physiologic range of movement, and a physiologic range only. That's what we're trying to achieve. If you can strengthen that muscle, those muscle groups, and I have spent a lot of time trying to do it, you'll find you simply nutate and dislocate your joint at a vastly diminished frequency, and maybe not at all. You may actually solve your problem. The issue is then doing it religiously. Just like you're learning to brush your teeth, very few people are doing their back exercises or their pelvic asymmetry exercises routinely. The other thing you have to do is stop the pelvic asymmetry, which means stop lying on your side with your knees not together. You might have to stop riding your bicycle without an SI joint belt, for example. You might have to stop doing lunges or squats below the horizon, which is about 90 degrees. So you're going to have to stop those things at least for a while to allow those structures to come back in, so the ligaments shrink back down to normal size. And in so doing, if you also strengthen up the muscle, you can put a lot of work of this joint on the muscle and less on the ligaments themselves. Let me introduce you to the gluteus maximus. You've probably seen one of these before, either your own or someone else's. It is, you can see it right here. It inserts right to the crest of the limb. It crosses the SI joint and inserts here into the lateral portion of the sacrum, and it goes all the way across and attaches, and actually this is a little wrong, attaches a little bit laterally on the hip. That muscle group is obviously an enormous muscle group. I find that people of color, people who have just genetically stronger gluteus maximi rarely have sacroiliac joint dysfunction because they have a healthy joint movement because of the muscle so robust. Let me show you the piriformis muscle as well. All right, here's another shot taken again off the web. You can see gluteus minimus, no help to us at all. Piriformis for sure, glomerular muscles, obturators, all of these are somewhat helpful, but it's locking the sacrum against the ilium that is of particular importance. Here's the piriformis. It runs anterior to the sacrum and attaches. It comes right over to the lateral hip. Interesting muscle. Here's the gluteus maximus that we saw earlier, again attaching here. So what one exercise actually helps with strengthening these without also at the same time stretching the SI joint, which is what you want to avoid? All right, so pretty simple. This is kind of like brushing your teeth. If you've had a sacroiliac joint dysfunction, hypermobility syndrome, dislocation, this is the set of procedures you need to be doing, the exercises. I personally do about 200 of these a day. There's beginners, there's advanced, and then there's expert, and I'll show you all three, but it's super simple. And there's really no reason you can't do this. Anyone can't do this at home. The aim of this is to tighten and strengthen the gluteus maximus as well as the piriformis and glomerular muscles, the three main muscles which secure and hold the joint in position and protect it from hypermobilization and ultimately dislocation. So here we go. All right, super simple. I told you it was. Lying in this position, and you simply do, you put your feet up, have a flat section. You're going to do a bridge. So you're simply holding your pelvis in this position. Holding the pelvis or going from lying down flat to that position. What you can also do, so that's the beginning move, try 200 of those a couple times a day, is put a TheraBand or a belt around your knees and try to, what we call abduct the femurs, which is spread them apart from each other, and hold that position while you're doing the lifting. So essentially imagine a TheraBand, or I didn't bring mine to work today, but you lift like this, pressing out 200 times like that. There's the advanced one. Then you can imagine what else could make it more challenging and difficult, putting a weight on your pelvis like a kettlebell, using the TheraBand and doing a couple hundred of those. That's expert mode. So if you do that, you will do a great service to your SI joint, because you'll ultimately limit its range of motion by the muscles that surround the joint. That's what I do. I found it to be incredibly effective at reducing the hypermobility that occurs there, and then also ultimately the risk of dislocation. So that's how to build the muscle around the joint. There's also a few things that can predispose you to nutation, which is certain muscle groups can be tight. And one of those main muscle groups is the hamstring muscle group. What do the hamstrings do? Well, they're in the back of the thigh, as you know, and they go basically from the back of the knee, back of the femur, along the back of the thigh, and they attach to the base of the ilium. I'll show you where they attach. So right here, at the base of the ilium, right there. And they go all the way down the back of the femur. So as you bring your femur forward, you can imagine you're putting a posterior moment on the ilium, again, putting your sacrum into nutation or flexion, forward flexion. So when you're side lying in bed, also what you're doing in throwing the leg is not only gapping the joint because the knees are together, but also then flexing the posterior ilium because of the tight hamstring. So one of the few things you can do to loosen up the hamstring is this procedure. I'll show you. A lot of people think stretching the hamstring is just bending forward and touching your toes. That will stretch your hamstring, but it will also cause the problem or actually nutate your SI joint. So the way in which you transfix the SI joint so it's safe, but yet also stretch the hamstring is this move precisely. So as you bend forward with your butt out at the femur. I'm not bending at the waist, I'm bending at my coxofemoral joint, at the way the femur joins the pelvis, butt out. And I come down here and I'm gonna have to bend my knees in order to bend forward. I put my head down on a table or on the bed, and then with my butt out, with my lumbar spine in extension, locking the SI joint, I then gradually straighten my knees and try and straighten my knees entirely. That will put a stretch moment on the hamstrings and the hamstrings only without stretching the posterior fibers of the SI joint. That's the stretch. Another muscle group you can shore up in order to strengthen or just put a counter nutation moment on the actual SI joint is the iliacus and the psoas muscle groups. Those are in the anterior pelvis, the front of your groin essentially. They attach at the back of the pelvis, go through the front of the pelvis to the femur. And if you work on flexion strengthening, you will actually cause counter nutation again. So if you resist, push up your knee, raise your knee against resistance, that muscle shortening, contracting is actually counter-nutating your ilium relative to the sacrum. I don't know if you've noticed, but none of the things we've been talking about talks about a needle, an ablation, a nerve, a block, steroids, or surgery. So a lot of sacroiliac joint pathophysiology can be treated by you, and ultimately by removing the predisposing factors that create hypermobility of the pelvis and SI joint, you can hopefully keep your joint healthy. However, sometimes it will be locked, it will be hypernutated or counternutated and locked in that position, or essentially dislocated. And you've been to the chiropractor, you've been to the PT, it can't be put back in, and you're living in extreme suffering, because that's what happens. Because now it's just like all those ligaments have been stretched and torn, and it's incredibly painful. There are a lot of nerves that go to the SI joint and the capsule and all the ligaments. So there's something called hydrodilation. That is a technique that we use in frozen shoulder, for example. It's when we fill the joint with a fluid, be it saline, some numbing medicine, other type of viscous supplementation like Synvisc, or type of lubricants for the joint. But there's, in so doing, there's a mass effect. And so one of the main reasons that SI joint injections actually work is that in placing medicine or fluid within the joint, and the actual volume of the joint is not very big. It's around half to 1 cc or milliliter. It's pretty tiny. But if you put a needle into the SI joint, and you have to put it in really at the base of the joint to try and get in there, or from the medial to lateral side to put it in the joint, and you have to use X-ray, fluoroscopic guidance to do it, or sometimes ultrasound if you're pretty handy with an ultrasound. But the idea is to inflate the joint with fluid or liquid and essentially unlock and decrease the space so that the two corrugated sections of the joint are no longer touching each other and can float. And hopefully they'll come back in position as the fluid absorbs, they'll come back into normal anatomic alignment. That's called hydrodilation. There's some other techniques, French neurologist term for it, which I've actually forgotten. But nevertheless, that's one of the basic ways to reset the joint. The other reason we put a needle in the joint is the following. We want to diagnose whether the pain from your low back, is actually from the sacroiliac joint, just like the CT I showed earlier. There's a lot of pathophysiology, there's a lot of anatomic variation going on. And so if we numb up the SI joint, and usually the constituents of our injections are a combination of a numbing medicine and maybe a steroid, and we numb up the joint and your pain goes away, well, then we have had confirmation that that's the bad actor. The SI joint truly is the pain generator, so to speak, and we should focus our treatments on the SI joint and not on, say, a bad disc or a facet joint or a herniated disc or sciatic, etc., all of which can be mimicked by the SI joint and can also mimic SI joint pain and dysfunction. So that's the first reason I pick up a needle, is I want to hydrodissect or dilute, force the joint back open, allow it to settle back into the correct nutation and alignment. The second reason is I want to numb the joint up and see if it confirms that that's where your pain is. If we do that, then it focuses all our treatment on the joint. Things can be a little difficult though, because sometimes the actual painful fibers arise from the sprained ligaments. And so placing the needle into the joint and numbing up the interior of the joint has really no basic relief. So it's been argued that an SI joint block, which is where we actually numb up the innervation of the joint, and that's basically killing the messenger, so to speak, temporarily. These nerves in back of the joint come over and they wander right over. They come out of the little holes called the sacroforamina, and they wander right over to the SI joint and innervate the posterior portion of the joint. There are actually some nerves on the anterior portion of the sacrum which do the same, a lot harder to get to. But if we numb up these posterior nerves and the pain goes away, we again have confirmed that the SI joint is the misbehaving creature in your back. and we'll focus our treatments on that. Okay, an intra-articular sacroiliac joint injection. There are a couple ways to do it and a couple reasons for it. One is to put simply steroid in the joint. This calms down the inflammation in the joint. It can have dramatic pain relieving qualities. I find in many patients that a single or a couple of SI joint injections can have such a dramatic effect that their problem essentially is gone. This doesn't work for everybody, but a significant proportion of my patients who have sacroiliac pain get good treatment and permanent relief, so to speak, from an SI joint injection with steroid. You may not want to use steroid. What other things can we inject into the joint? There's all kinds of things I've heard about, read in the literature, etc., used myself. And so probably the second on the list is going to be viscose supplementation. I think this, and that is things like Euflexa or Synvisc or Hyalgan, hyaluronic acid, all the same things we inject in knees and hips. Also in horses, they call it rooster juice on the racetrack for horses. But nevertheless, we inject that into the joint. If you have an arthritic SI joint, it actually improves motions considerably, removes pain. It can also be one of those things, those non-steroid treatments that we use to unlock the joint when you're locked in nutation. And so I've had that myself. One of my partners had to inject some Synvisc into my own joint and instantaneous relief. And out of the nutation, lock, dislocation situation, then back to the gym to focus on the gluteus maximus and piriformis and gluteal muscles, glomerulis. So, number 3, PRP. What is PRP? You guys have heard of it, I'm sure, if you've been around orthopedics at all. It is platelet-enriched plasma. We essentially take your blood out of a sterile access from your arm or something like that. We spin it down. We get rid of the inflammatory red blood cells and some of the other constituents and focus on mostly the platelets and the serum, and we re-inject and concentrate those platelets back into an injection into whatever structure we're aiming for, be it the SI joint or some tendons, knees, etc. In the SI joint, it has a similar effect. I tell patients it's essentially your body's own steroid. It is the chemical mediators of anti-inflammation designed by you for you. Within those platelets exist interleukins, interleukin-1 receptor antagonists, as well as a host of others, which essentially control the healing process and move it towards anti-inflammation. There's some argument that it also increases tissue building, such as cartilage deposition and others. The data on that's a little thin, to be honest. I think it's just a really good anti-inflammatory. But nevertheless, that can be injected. Non-steroid, it does work, also has the same mass effect on the joint, gradually diluting or hydrodissecting the joint so that it falls back into place. Okay, let's say you've had all the injections and you're just not getting anywhere. And you're thinking about a fusion. A lot of folks are advocating for fusion. Historically, about 20 years when I got out of fellowship, they were essentially fusing the SI joint using pedicle screws, driving large, big self-tapping screws through the wall of the ilium from this angle into the actual sacral ala or the sacral wing, and securing the joint in that way. It was almost a joke when I was in fellowship that one of the guys up in Atlanta who was doing so many of them was just basically providing all the patients to our clinic. And that was essentially a failure, and it was a failure for a variety of reasons. Number one is the complication rate was ridiculous. There's an artery, the superior gluteal artery and middle gluteal artery exist right here. A lot of times people drive the screw through the artery. It's a large artery, and most people trying to do this in a minimally invasive fashion. You have uncontrolled bleeding. I've heard read surgical reports of people losing liters of blood into their tush, basically, almost bleeding out because of this nicking of the artery without visualization. Normally, when you're doing surgery, you nick a big artery, you're there. You have enough exposure within the surgical wound that you can then ligate and trim or secure the artery, provide hemostasis that way. This is uncontrolled bleeding. Number two, the joint in this way wasn't designed to be fused. and the actual hardware itself would fail. Those pedicle screws are not designed for the SI joint. And the point of rotation, they'd put the two or three screws so tight together that the axis of rotation would be hardly limited at all. It's kind of like it's very easy to turn a wheel if you grab the outside of the wheel and turn it. Those are the physiologic forces that normally impart on this joint. However, if you try and limit motion, you want to counter the movement, not on the inside of the wheel, but on the outside of the wheel. And so they would fail in that regard. So not trying to go to surgery, a lot of people worked on other ways to treat pain. So attention was turned to something called radiofrequency rhizotomy or ablation or cooled RF, all attempts to interrupt and destroy the messenger, carrying the painful message from the dysfunctional and painful joint to the brain. And so in folks, we find that most innervation, and I say most because it's really probably 60% of cases, have a majority of innervation that occurs through the posterior lateral branches of the sacral rami, the sacral nerves. And so S1, 2, 3, and 4 keep the poop off the floor, but they also innervate the SI joint. And those lateral branches come over here. They don't go to your bladder or your bowel, luckily. They only essentially go to the joint. And so the idea was if we could numb up and ablate or thermally destroy the nerves right as they entered the joint, we could, in the same way we treat facet arthritis, which is right nearby, we could provide anesthesia to the joint and people would have pain relief. I've done hundreds, if not thousands, of SI joint ablations in my career, blocks as well. I will tell you that I think I'm about 50-50 on those. The people that respond to the block, about half of them get meaningful relief. The other half really no worse, but sadly also no better. This is just my experience doing thousands and thousands of treatments for SI joint problems. However, for the 50% it works for, it's wonderful. You've just denervated, you stop the pain in the joint. It's not that the hinge is not working, it's working just fine. It's just squeaking too loudly, so we essentially controlled the sound. And that's what we're doing by ablating the joint. Why does it not work all the time? My estimation is that a good portion of the time there's anterior innervation of the joint, anterior nerves that go to the joint from the front. We can't put a needle there. It's next to the bladder. It's next to a lot of nerves going to the bowel, bladder, etc. We're not going to ablate those nerves. Those are nerves you need. And so by ablating them, you're going to have a complication for sure. So we don't even put a needle into the anterior sacrum ever. Because nothing's perfect and not all these things work, there is fusion. And this is a big step for folks. It's what I try and help people to avoid, but nevertheless, it can be life-changing in the positive for folks. If you recall back, one of the main reasons people have pain in the SI joint is because there's hypermobility, and as we walk, that joint has now worn and is working too much. The range of the joint is probably way greater than the 1.5 degrees you were born with and as a teenager. And now it's 3 to 5 degrees of movement. And every time you take a step or move or change positions in bed, you're feeling that pain in the spot because the joint has moved beyond the physiologic range where it's designed, and you have painful areas of bone grinding on other painful areas of bone, and the ligaments are also torn and under tension the wrong way, to explain it as well as I can. So, two concepts exist regarding fusion. The first is a direct or posterior approach. This type of approach, and the companies that do this are blossoming like mushrooms after rain because it's pretty simple. It actually pays the physician fairly well, and it has a low risk. There's certainly no risk of nicking the artery from a posterior approach. And what we're trying to do is follow the trajectory of the joint, dilate the joint with a series of surgical dilators, and then place within the actual joint a spacer. We call it a fusion because that spacer is commonly bone that we've taken from cadaver, and we've roughed up the surface of the joint and expanded the joint, removed and separated those painful arthritic surfaces from each other, so now they're not grinding on each other anymore. But we've also put in a piece of bone which attempts to fuse the joint over time. This is sadly imperfect. It works commonly. I'd say around 80-90% of the time people actually get very good results and time tested. And over time, that little piece of bone then ultimately fuses and bridges between the two articular surfaces, doing exactly what I was showing you will happen if you go to space with the pelvis that my patient had. You're accelerating that process and reducing movement. The other way it works is it separates and tensions up, physiologically tensions those ligaments so they work appropriately. Sadly, that does not always work. So I've had a few patients who've gone through it and that does not help. And then what are we left with? And at that point, we're really left with a variety of lateral and superior lateral approaches that do attempt to bridge and cross the joint using metal, usually titanium, and driving a screw through either from the outside in. This is again the gluteus maximus and medius are sitting right here. So you're driving from this location. The gluteal arteries are here. I would recommend that your doctor get a CT to evaluate the actual anatomy of the vasculature. A CT angiogram, we call that. You can also have MR angiogram that'll show the relationship of the arteries, see if they're in position, see if they're in a place that you would drive your screw. So that's key. The other way to approach it is there's another superior lateral approach which exists. Again, I'm not using any names, but where you take a screw and you come, instead of from the side, you come up from this angle, which is a superior approach, come right through the crest of this bony segment here, and then drive across the joint, fusing from a superior lateral approach, that probably being the safest approach. I like the best also because if you remember back to our wheel description and the function of the radius, the distance from the center of rotation dramatically increases or decreases the amount of force necessary to move or transfix the joint the further you are from the center of the circle. And because of that, you actually get a much more powerful moment of restriction of movement from the superior lateral approach. I'm trying to think if there's anything that I've missed. It's a big deal, this joint. I've seen lives destroyed by it. How do you know it's your joint that's the issue? Let me talk about that. All right, so how do you know it's your sacroiliac joint that's misbehaving? You got back pain. Okay, what's the usual presentation? Well, the normal presentation, and everyone is not normal, is that you have essentially unilateral pain or lateral pain. It's not necessarily center of the spine pain. It's off to one side or the other. And when it's both, it's off to the sides. It's at that spot I was showing you called the Fortin finger spot. And that SI joint is usually painful in the joint. It commonly radiates down the leg. It can mimic sciatica. Commonly people will have a bout of it when they were simply doing nothing. They didn't have a car accident. They weren't in a bar fight. They simply bent over the wrong way. They picked up the sock. I did it once turning on the gas on the grill. I stood up and there it is again. It can be the most benign of movements. Sometimes you wake up or you're stretching, things feel a little funny right back there. You feel a little kind of heat or coldness in the area. It feels a little weird. And then later in the day, you've done something. You twisted getting in and out of the car, for example, and you've done it. You've dislocated your sacroiliac joint. You know also because as you're going through and you're living in extremis in that pain, before you've seen someone like myself or some other physician, and you're essentially undiagnosed and untreated, that rolling over in bed is exquisitely painful. I would say that's probably synonymous with the condition around 90% of the time. Changing in positions in bed. Not once you get there, it's a little less painful, but rolling over is what hurts you. Getting in and out of a car. A lot of people change the entire way they get in and out of the car. They move their legs symmetrically together, rising from a seated position, sitting on the toilet seat, rotating your pelvis back and forward causes pain on that side, in the spot. If you have those signs and those symptoms, think SI joint. It commonly is the issue. I would note when I was out, nutated out, even if I tilted my head forward, I'd get a little pinch. And when I go see my Magic Hands physical therapist, who I owe a lot to, Robert, thank you. I would know if I'm in or out just by doing that little movement. If I could just bend forward, I'd feel a tug on the joint. And if it's pop back in, you know it because all of a sudden you have freedom of movement without pain. So that's how you know. That's how you suspect. How you really know is when you numb up the joint and the pain's gone. That's confirmational. That's diagnostic. I think I'm going to close it up. I really appreciate your attention. Hopefully, I've said some things that have given you access to knowledge or a new way of thinking about this issue, given you some pause maybe. Maybe I've given you direction. Nevertheless, I hope I've helped you. And it's a pleasure talking to you. Thanks. One last thing, the SI joint belt. Almost forgot. Something you can get at home. Available on Amazon, or actually I think I've seen it in the drugstore. It is a belt that you wrap around your pelvis. It's called Sacroiliac joint belt or SI joint belt. There are a million of them on Amazon. The key is to find one that is wide enough and yet thin enough. Wide enough in its dimension that when you cinch it up, it does not pinch you. A tight belt that's only 1 inch wide, for example, is going to cause pain. You want it tight enough that 1 inch wide belt would cause pain. You want at least 4, 5, maybe even 6 inches. And the idea is to place it. I commonly, if I'm having a bad time, I put it underneath my scrubs or underneath my clothing, and you put it low on the hips. You know, a normal back brace is up here. Lumbosacral LSO orthotic is up here. SI joint belts really, here's the crest of my ilium right there. So I'm going low. Here's the trochanter of my hip. This is the lateral portion of my hip. So right in that position between the two, and I cinch it together, and that's also we call it pathognomonic. It is synonymous. If you have SI joint pathology and you put on an SI belt and you cinch it up and you feel vastly better, it to a large degree confirms the diagnosis also. If you have a herniated disc or facet pathology or spinal stenosis, it does nothing to change the architecture of those problems. So if you find a dramatic improvement, again, it confirms likely that you're suffering from sacroiliitis. Again, thank you very much. Best to you.